Good afternoon. My name is Bluma Zuckerbrot-Finkelstein, and I'm Executive Vice President of Memphis Jewish Federation, the central convening, planning, and fundraising arm of the Memphis Jewish community. I'd like to welcome you to the second program in our series, The City We Share, Community Conversations Through a Jewish Lens. The idea for this series was born after Federation joined MIFA's Fall 2020 Community Read of Matthew Desmond's book about eviction. From that program and our own book discussion, we learned that there was Jewish community interest to learn more about the complex challenges facing our city and the innovative initiatives to try and address them. Last month, we learned about eviction, and today we will explore the intersection between policing and mental health. I'd like to thank the committee members who helped conceive of this series and secure our speakers. Janice Finan, Federation Chair Cindy Feinstone, Jamie Johnson, Jerry Moskowitz, Eileen Posner, and Karen Rubnitz. And I'd like to express our deep appreciation to all of today's presenters who are taking time out of their very busy schedules to share their expertise with us. A few technical points. Please stay on mute for the duration of the program. We have allocated time at the end of the presentations for questions. We will be using the chat function for questions. Feel free at any time during the program to place your questions in the chat, and we will get to as many of them as we can. I'd like to now call on veteran Memphis mental health professional and administrator Judy Bookman, who will moderate today's program. Judy has held numerous professional and volunteer positions. Currently, she is the director of Judy Bookman Workplace Behavior Consulting, the chair of the advisory committee for the Wendy and Avron B. Fogelman Jewish Family Service, and a board member of the Jewish Foundation of Memphis. Judy, take it away.
Thank you, Bluma. Welcome, everybody. I'm smiling because there are people I haven't seen in a long time, and it makes my heart so happy. I'm pleased to be able to facilitate this program today, and I would like to just say a couple of things about the content. Work with the police and people who have a mental illness is not anything new, but I am guessing that we are highlighting it because it is a significant problem these days, and we have become more aware of it, as well as the fact that people are working with the police so that we can ensure better outcomes. And of course, more about that from Laurie Powell when I introduce her. But first, I'd like to talk about and introduce Rabbi A.B. Schachter Gompel. Rabbi A.B. serves as the Director of Spiritual Care at the Memphis Jewish Home and Rehab Hospital, a native of New York, which you'll never be able to tell from the way he speaks because he's gotten a Southern accent now. He completed his first unit of Clinical Pastoral Education, CPE, at Memorial Sloan Kettering Cancer Center, and did a year-long CPE residency at Methodist Lebanon Healthcare here in Memphis. A.B. studied at Yeshiva Chavevi Torah Rabbinical School and was ordained in June of 2017. He is a board-certified chaplain through Neshama, the Association of Jewish Chaplains. He's married to Rabbi Sarit Horowitz, and they are the proud parents of their son, Levi Hirsch. Welcome, Rabbi A.B.
Thank you, Judy, and thank you to Bluma for the invitation. Judaism believes that how we treat the most vulnerable is not only a duty of the individual, but speaks to who we are as a community. There's a beautiful and poignant teaching in the Talmud that I wanted to share today that I think can offer a helpful framework for our conversation. The teaching is based on a verse in Deuteronomy that describes how Moses was instructed by God to carve out a second set of tablets. Remember, Moses broke the first set of tablets that he received from God at Mount Sinai after descending from the mountain and witnessing the Israelites' sin in creating and worshiping the golden calf. Whatever happened to the first set of tablets? Rabbi Joseph taught, the second set of tablets and the first set of broken tablets are both placed in the ark. According to Rabbi Joseph, the first set of tablets were not discarded, but in fact were collected and placed alongside the second set of tablets in the ark. The broken pieces and the whole pieces were housed together in the holiest of spaces. The ark lies at the center of the Mishkan, the portable tabernacle that the Israelites used to conduct their worship in the desert. You may even say the ark represents the heart, the innermost core of the Israelites' ritual space. With that in mind, Rabbi Joseph continues, "From here we learn that a scholar who has forgotten his learning out of force, we do not treat him disrespectfully." Rabbi Joseph is interpreting the tradition of the broken tablets and the whole tablets creatively. That which we see as broken, a scholar, and I'll personally add any individual who has forgotten his learning or her learning out of force, who has sadly lost their way by no responsibility of their own, you must see and treat with the same reverence as something that is whole. That which is broken, or we might reframe in a more nuanced manner, that which you see as broken maintains the same status of holiness with that which is whole. What you may see as broken requires you to provide the same dignity as that which is whole. As Jewish people, we need to strive to follow the words of Rabbi Joseph at all times. But perhaps this is most needed in a moment of crisis, like when law enforcement is called to the scene and they encounter an individual who we might call a broken tablet. How should they interact with this person? The second set of tablets and the first set of broken tablets were both housed in the ark. We need to ensure that the institutions of our community respond to the broken set of tablets with the holiness they deserve.
Rabbi Aby, thank you so much. We appreciate your words and appreciate the idea that you're giving us a Jewish framework in order to hear Laurie. Thanks very much again. Let me introduce Laurie. Laurie Powell serves as CEO of Alliance Healthcare Services, known in the community as AHS, which provides behavioral health and addiction services to over 22,000 individuals and families at 11 locations throughout Shelby County. AHS partners with many community agencies to support access to care issues for all individuals in need of these critical services. Ms. Powell has worked in the community health field for over 28 years and is a licensed clinical social worker. She previously served as Vice President of Clinical Services and Deputy Director with Alliance Healthcare Services. Ms. Powell is a member of the Tennessee Association of Mental Health Organizations and currently serves on their board of directors and legislative committees. She has also served on Mayor Strickland's Community Health Steering Committee and the Shelby County COVID-19 Task Force representing behavioral health. She is dedicated to partnering with the community to promote wellness, which is the mission of Alliance Healthcare Services. Ms. Powell received a bachelor's degree in psychology from the University of Memphis, a master's in sociology from the University of Memphis, and an MSW degree from the University of Tennessee, Knoxville. Welcome, Laurie. We're so glad to have you today.
Thank you. I'm really excited about talking to this group and really felt the passion about the topic when I met Karen through the Micah group. So excited to be here. And I guess we can start with I wanted to start with a video first and then about our care team. It's a new pilot that we have with the police, the fire, and Alliance.
My name is Jane. Went through some traumatic things. My parents dying, losing a job, foreclosure on my house. I called the crisis number and I asked them to please take me to the crisis center.
On when someone is available.
Yeah, got one. Yeah.
On a 50-year-old black male thinking about suicide.
Many people across the country have been talking about how to respond to people in a behavioral health crisis.
Here in Memphis, we've been working on a team called the Crisis Assessment Response to Emergencies. And the care team is a perfect example of responding to someone who has mental health issues in a humane way.
And so those calls that come to us that are behavioral health emergencies, we send our care team instead of sending an ambulance.
Once they're on the scene, they're going to make contact and see what avenue would be best for that individual.
What about a mental health diagnosis?
It's almost like a one-stop shopping. You got the behavior analyst, you got the law enforcement officer, and you got that paramedic EMT there. So whatever's going on, we're basically able to handle it.
So before the care team came about, we identified about 100 individuals who were overutilizing 911 services.
So in looking at that, the care teams thought of to ease the burden to the 911 system and provide better services for those people in need.
In 2016, I took all my medicine trying to end my life. When you feel like you're by yourself, you feel like you don't have a reason to stay on the earth.
So once we get there on the scene and it's determined that that person needs a higher level of care, as we like to say, we are able to take the person to the Crisis Assessment Center. We can provide medication management there on scene. We can provide individual therapy. We can refer the client to our crisis stabilization unit, as well as refer the client to an inpatient facility if that's what's needed.
It's making people feel like that there's a network, there's a community of support around them. That you feel like somebody care about you. And that's what it's about, care team. We care about people.
Probably the biggest change I've seen is my determination and will to keep going. If you seek to get help, you'll get help.
I just feel like I have someone that care about me, and that makes a difference.
I believe that the model that we've demonstrated here in Memphis for nearly 2 years now is a wonderful model that can be scaled up to serve even more of these persons in our community and can be replicated throughout the U.S.
We gotta get dollars to keep this program going. That's what's gonna be the deciding factor. Is it gonna be successful? It's already successful. It goes without saying, it is already successful. All right, but can it be more successful? It certainly can.
Hey. All right, so I was really excited to do that video, and the people that you see in that video that we served, they were so ecstatic to be asked to tell their story. And since that video, we've made a few others about our programs, people who want to share their addiction, their pain, and I think that's healing for them. So kudos to all of us getting together, the three systems, to try to, you know, address this, I'm going to call it a crisis across the country. I wanted to tell you a little bit about our agency first, and if we could just start with the first slide. So Alliance Healthcare Services, we're a 501c3 nonprofit, and there's our website there, and our mission is promoting wellness in our community. Our mission used to be 2 pages or something, and so we promoting wellness, that's what we want to do, and that's what we'll continue to do. Next slide. There's our outpatient clinic locations and our crisis services location. I didn't include our housing locations, but we have housing throughout Memphis and Shelby County for those who have a mental health diagnosis and need housing, and we're continuing to expand the housing that this population really needs. Next slide. And then there's just a little bit of history about the 18 locations include all of the housing that I haven't included, and we now we're about to 430 staff. So when I started in '93, we had about 120 staff. Now we're up to around 430 as the need continues to expand for our services. Next slide. And we did something fancy here. Psychiatric services, there's all the services that we provide. We have pharmacy locations in 3 of our clinics, and we serve starting at age 3 all the way up to the end of life. So several grant programs for parenting and children and youth, trauma-focused interventions, etc. So that's just a little bit about what we do. Next slide. So today I wanted to focus on the interface that we have with the police, and that's our crisis services. So we have mobile crisis, which goes out into the community, and we actually are in all of the hospitals in Memphis as well. Our crisis assessment center is currently located in the 2nd floor of MMHI, and we have a 23-hour walk-in observation there. And there's a police diversion unit as part of that operation. That used to be housed in Regional 1. And at that time, the police would bring people into the emergency room at Regional 1. And unfortunately, they were handcuffed to the bed there in the past. But now that's the police drop them off and they're on their way. 10 minutes tops at our crisis observation unit. The crisis stabilization unit is if they need a higher level of care, 3 to 5 days. Intensive respite, maybe they don't meet the criteria for the crisis stabilization unit, but they just need a place to kind of calm down, de-escalate, get away from a negative environment. That's what respite's for. And then the medically monitored withdrawal management. And that's people who need to be detoxed from alcohol, opiates, and benzodiazepines like Ativan, etc. And next slide. Oh wait, pre-arrest diversion, thank you. Pre-arrest diversion is highlighted in blue because that's really what we're going to talk about for the most part today. The care team, you just saw that video. The police diversion, which I mentioned, that they bring people that call into 911. The police might go out, see that they have a mental health diagnosis, and bring them into our walk-in center, which is the 23-hour observation. And then we created something called the enhanced follow-up team, because we realized we needed another level of intensive outpatient where people are coming into crisis more than once or twice in a 3-month period. We linked them to an intensive 24-hour treatment team in the community. And next slide. So pre-arrest infrastructure project. This was a grant that we received in 2018. The Department of Mental Health funded, they sent an RFP out and we responded and wanted to try to create a few things outside of the box. So we talked to both the city and county government leaders, the fire department and the police department. And we said, you know, we asked them and some other community leaders, what do you see that we might need here in Memphis and Shelby County that we don't have right now to address those who we're trying to divert from jail that really don't need to be there. And we came up with the idea for the care team. And at that time, I'd never heard that there were 100, it was really like 111, 115 people that were calling 911 more than 4 times a week. And we said, what can we do for that group? So we realized that we could create this care team and go out. When they would call 911, these individuals would be flagged and we would go out and try to address the problem, because what we found was maybe they were having a severe anxiety attack. They thought it was a heart attack. But the EMT is a critical part because we wanted them to be checked out medically before we determined any kind of treatment solution. All right, next slide. So the number that we serve in Shelby County, a lot of people don't realize that we are the largest crisis system in the state, one of the largest in the country. So we assess around 15,000 individuals a year who are experiencing a behavioral health crisis. Now those are age 18 and over. I want to emphasize that. We are funded for the crisis intervention for 18 and over. Youth Villages has the crisis for under 18. We have the highest police diversion, that's police drop-offs in the state, which we are proud of, and we hope to increase that. We put the diversion rate as around 70% from inpatient level of care. What we found is people were waiting in the waiting rooms, emergency room, sometimes 10 hours. So we came up with this partnership with Baptist, Methodist, Regional 1 to really kind of steer them to the psychiatric care that they needed. And we put the cost savings. That's just one of the cost savings studies that we did based on how many days someone with a mental illness that has a misdemeanor might spend in jail, and then the emergency department savings. And next slide. So the care team, you saw the video, has a therapist, the EMT, and the CIT officer. And one of the things when we first met as a group is, how can we streamline the process? You have somebody calling 911 and the police are dispatched. How can we get the 911 call to the care team? And so we're still working on that. That's a work in progress, because I think right now we're responding to around 100 911 calls as the care team, but I think we have an opportunity to do a lot more. And that's going to take, somebody from Micah brought this up and I appreciated their feedback. I do think it's going to take training our 911 workers more on identifying a mental health type of call. Next slide. So here's some data. Okay, I'll look at those questions. So here's some data on the care team. And this is going to look like foreign stuff to most people, but we kind of wanted to look at how many we served. This is just from January to 2020. I think that's actually supposed to be July to December 2020. So somebody had an error there on my side of things. But anyway, there's the total served was 1,056. And then the percentage of the different categories. Maybe they needed a safety net plan. Maybe it was resolved on the scene and they didn't even need to be taken to a crisis center. And then out of those, 192 were taken to our crisis walk-in center. So what we were finding is some people could be assessed on the scene and then linked to a type of treatment they might have needed. Next slide. The familiar faces, we went to a few other crisis centers across the country. One of the largest is in Tucson and Phoenix, Arizona. And they told us that it's better to call them familiar faces instead of frequent flyers, because that dehumanized. So we started saying, okay, well, familiar faces, those are, and not high utilizers, even though we have high utilizers there, but our familiar faces, we started tracking the data from those 111 who initially were calling 911 3 to 4 times in a week. And there's the number of assessments they did during that time period, and then the care team assessments. So we had a 50% reduction in those who were interfacing with our crisis unit after we implemented the intervention. And we looked at linking them to our outpatient. So that's where our follow-up team comes into play. We realized that these individuals, they couldn't have just a regular routine outpatient therapy appointment where they're seen maybe a couple of times a month. They needed to be seen sometimes 3-4 times a week because they lacked the social support. These are people that we found were extremely isolated and had a limited social support. And so there's some of the data regarding linkage to the outpatient services. And we had a 35% increase in connecting them to our services, because this group of people, we had a hard time with linking them to services. We would give them a follow-up appointment, and what percent of 911 calls? Okay, well, I'll get to those later. All right, next slide. And so there's the care team service utilization data that we increased the outpatient services. That's just a graph form of what I just reviewed. And next slide. The enhanced follow-up team, they had an average of 2.4 hospitalizations during a year's period of time, and it was reduced to less than 1. And so, and then we looked at who is currently assigned. So it's because some people rolled off of being in the follow-up team. Some people needed just basic outpatient once we got them in the level of treatment they needed, and on medication, back on medication, some of them. So the total hospitalizations right now has been reduced more than half. And next slide. And there's the total admissions to our crisis unit, where you can see it's been reduced more than half. That's our crisis stabilization unit. Next slide. So we created this next slide because I'm talking to payer sources. Medicaid is one of our primary sources of funding, as well as the Department of Mental Health. They fund us with grant dollars for what we're doing. And I feel like Memphis continues to be underfunded, and I just needed to show the data. And so that's something that really spoke to our state's Medicaid system. So there's the cost savings. They want to see when our payer sources say value, they want to see what it's saving. You know, the bottom line is, how did you reduce hospitalization, and are you linking them and keeping them stable in outpatient? And so there's your total cost savings. I know that's a huge number. We double checked it 3 and 4 times. And then the state came back and said that's exactly the same data they had. So that made me feel pretty good. Next slide. And okay, so Tennessee, funding for mental health is a big issue. Tennessee is not a Medicaid expansion state. The reason I bring that up is when I go and visit other states and I see all of the things they've been able to do with the Medicaid expansion, it's just really incredible. There's a place in Denver, Colorado that has a place called the Dahlia Center, where it's a one-stop shop for everything. It's got housing, it's got an aquifer thing there. It's got they have fish fries every Friday. They have, so anyway, and the CEO there said, well, Laurie, we're a Medicaid expansion, so anybody coming in that meets this criteria, they have more dollars to work with. That's really the bottom line. Now we do have something called behavioral health safety net, and that has really expanded. The behavioral health safety net is for the uninsured who meet a certain income level, and we can offer them the mental health services through this safety net. We have to complete this paperwork, show they need behavioral health services, and it's linked to their level of income. And so there's some other facts. It's community-based, but you know, here's the thing. There's no safety net. We'll have these individuals enrolled in behavioral health safety net, but we link them to some of the community providers, and there's still a cost to that patient. A lot of times we try to cover that cost. It might be $25, $35 for a routine physical and things like that, but I would say that's a big hole, that there's no safety net for everything a person needs. And next slide. There's the percentage of who we see right now and the funding. So you can see the majority of it is Medicaid funding, and then the safety net that I just mentioned, Medicare, and then grants. I think that's our last slide. So for the grants, those have really increased. We try to find any and every kind of grant. So we were just awarded, and the Memphis Flyer had it, the Daily Memphian, and the Memphis Business Journal. We were just awarded $4 million to become a certified community behavioral health clinic. I'm so excited about this because before it was you were only eligible to apply for this funding if you were in a Medicaid expansion state. That just rolled out the very first of this year. We applied for it, we got it, and so we plan on using those dollars to just further enhance what we're doing here. Hire more psychiatrists. If anybody knows a psychiatrist, I pay pretty well. We need a child psychiatrist, we need adult psychiatrists. I have 6 psychiatrists, and when we need, like, I'm gonna say 10. UT only graduates 2 people a year, and so I'm trying to court and, hey, come join our team. But you have to be passionate about community mental health. It's not for everyone. I've been doing it since 1993. I thought, I'm going to get my master's and I'm going to go do this. I stayed and I fell in love. That's not for everyone. And my other leaders, we've all worked together for almost 25 years. So they feel the same. But I think we've got some questions, and I can't wait to have a conversation. And sure, we actually just started accepting private donations. But Judy, you wanna ask me some of these questions, because I know you're.
Well, before I do, Laurie, may I make a couple of comments? And one is, sure. I think your positive outcomes since 2018 are staggering in just a magical way, because I think we know that the problem has been over the years that people continue to access services without very much resolution, and sometimes with non-compliance. And when I see certainly not just the dollar numbers, but the numbers of people who have had the services, but are doing, I've got to use the word, who are doing better now. These are amazing results. And I take my hat off to you and the people who are performing the day-to-day, because you and I think many of the people who are listening know that working with people who have the issues that the clients or the familiar faces that you work with have, they're not always easy to work with. It's always a challenge, and you don't know when you go what you're going to really find, because there's sometimes a gap between what somebody calls and says and the reality of when the team gets there. So hats off to you. One of the things I wanted to ask you is, and I know how much money you're saving, do you have a handle on how much the program actually costs? Because you're staffing it with professionals, and when they're doing it, they're not doing anything else.
Right. That's a good question. And Micah just asked for the total budget of the care team. And so I can only speak for Alliance. I've asked the police and fire to turn in their data, and we're gathering that. But the master's level therapist, right now we're not operating 24/7. So let me say that we did get an extension of a grant from United Healthcare. And so those grant dollars are going to this care team. So that's, for 4 therapists at $50,000 plus benefit, I'm going to say the Alliance is around $300,000. The police and fire, like I said, we're still waiting for the data for that. But I am hopeful, and we will be using some of these grant dollars that we just got for the care team.
And you said it's not staffed 24/7. What is the staffing like?
Right. It's Monday through Sunday now, but it's it varies based on the need. Right now, it's starting we found that more calls were coming later in the day. So now we're starting at around 11, 12-hour days, like 11 to 11.
Okay. So if there's a crisis that happens after 11 at night, do the police bring them straight to your unit?
They'll assess them and decide if it's a mental health crisis, they'll bring them to us. Okay. And that's a whole other topic too, is calling 911 and identifying correctly, does the person, need mental health? So we'd like to train the 911 workers to identify more. We think that's probably something that would be a good thing to do for the community. Yeah.
Right. And we know those calls can be really, really challenging.
Absolutely. Something that turns out you think it's something else. Somebody has a knife, and just to go back real quickly, CIT was founded in the late 80s, and it was founded after somebody was self-cutting and they were suicidal. And when the police showed up, they said, this person has a weapon. The guy was shot to death. And so I'm going to say that I call CIT was founded here in Memphis. It's something to be proud of. They have 40 hours of training and continued training each year. But the model needs to continue to grow and progress.
Right. So prior to 2018, CIT had been around, of course, since the 80s, as you say, and it still provides a cushion for when you all are not using the care teams when they're not scheduled. Okay, I'm going to go ahead and hope that you will answer the questions.
I'm going to do it my best shot.
Okay. Somebody has commented the video is extremely powerful and want to know if you can share the link.
Absolutely.
Okay.
I think Bluma, please send that out.
Okay.
Send it to everybody who's on the call.
Okay. Thank you for that. From Megan Keel, how many care teams are available on a given shift?
It's just one care team. That's the thing. The care team, before we didn't have a care team, the police were all bringing them to our crisis unit, which, you know, at least it's still diverting them from jail, but meeting them on the community where they are is even better.
Okay. Lisa Harris has asked, what percent of 911 calls are the care teams handling?
Very, very little. It's only 100 right now a month. It started out at 35 calls, and just the more education that we're doing. But I think part of it is, and I can just tell you, I think CIT police are called out on more than 15,000 calls a year, and that's just CIT. The total 911 calls, I really don't have the answer to that. I should have gotten that beforehand. But if you look at 100 out of that amount, that's very few. And so that's one of the things. And I did, you know, I will tell you, Mayor Strickland, Mayor Harris, Director Rawlings, I emailed them with all kinds of ideas, and they respond back pretty quickly. I think that they're passionate about, you know, making a change. Change does take a long time to happen, longer than I'd like it to. I'd like to have an idea and boom, tomorrow it's done, but it doesn't work like that. But
and I, of course, want to remind folks that a 911 call can be anything from my dog is in the ditch to my house is on fire. So the 911 calls that come through, of course, are so widespread in terms of what people call about. And we know that some of those could be diverted, but once you've called 911, you're already in the system.
Right.
I say diverted, it's because they may not really reach the level of an emergency. Okay, I think you're going to like this question.
Ooh, okay.
Does AHS accept private donations?
Oh yeah, absolutely. And we joined Community Foundation. Now my compliance director is finishing our Community Foundation site. And I thought it was done, and then I found out it wasn't. But you can go to our website and donate there as well. There's a donate here button on our website. And the Community Foundation gave us a grant just because of our increase in COVID-19 services. We served 500 additional people in just the first 2 months, everybody. 500 so the need is going to continue to grow for what we do here. And as an NHSC site, not to digress too much, NHSC, we can hire doctors, we can hire therapists that are licensed, help them pay off their student loan because we're considered an underserved category, and that really helps us offset the cost, and we don't turn anyone away without the ability to pay. That's always been one of my, since I became CEO in 2018, we do not turn anyone away without the ability to pay. They're coming to us in crisis. We'll figure it out.
Do you also, I know you have Medicaid, Medicare, et cetera, as funders. Do you also have a sliding fee scale for people who have no insurance?
Absolutely.
Okay, and Megan Keel also asked, what would your ideal breakdown of funding sources be?
Well, for TennCare, which is, you know, we serve the underserved, but not all of those are TennCare Medicaid population. We have a lot of people that have lost their insurance that come to us, especially for our dual diagnosis program. We've seen an increase in people who've relapsed from alcohol and drugs. And that,
right. Just a second, I want you to explain what dual diagnosis is.
Oh yes, thank you. I talk shop, and then that means they have a mental health diagnosis and they also have an addiction diagnosis. And you see the two go hand in hand a lot of the time. Somebody might be drinking because they're depressed, or using opiates because, you know, they're anxious and depressed. And so we've seen that group that we've served. And I hired a psychiatrist who's so passionate about getting people into treatment quickly. I'm real excited about him, but he's a addictionologist. So,
Okay.
but the dream would be just a wider payer mix, which we are working on. Like, we do take Cigna, Blue Cross Blue Shield, and just, you can't solve this problem, but have it not every payer source be so complicated and have a different process and paperwork to get paid. But that's a whole nother conversation. So, but I you know, the grants that we've gotten from the Department of Mental Health, first episode psychosis, for example, they've continued that on since the inception, just with our data outcomes. And I think due to COVID, we've seen an increase in grant funding for, I mean, it's still funded less than primary care, everybody. I mean, I met with a group of legislators last week via Zoom for Day on the Hill, Behavioral Health Day on the Hill. And I let them know, let's just look at Medicaid. 25% primary care gets 25% more reimbursement than behavioral health. Why is that? I mean, we've got all these congressional acts with the, you know, Parity and Funding Act that Obama did. And, but I think that we'll see that turn around as we continue to have these conversations.
Okay, thank you. From Rabbi Aby, it sounds like you are doing incredible work. Can you share more about what Medicaid expansion is? And why is it that Tennessee did not expand it? What are the opposition's arguments?
Well, that's a really complicated question. I will say that, you know, don't want to get into politics too much, but we're okay, I will. Tennessee is primarily Republican state. Republicans historically are against the Medicaid expansion. The arguments being that you're held to a certain guidelines, and that even though they'll match a certain amount, you know, you'll have to agree to pay a certain amount. It's a lot of it's about control over those dollars, right? I tried to make that as simple as possible, but.
Okay, we appreciate that. From Jocelyn Wurzburg, in your opinion, Laurie, is a uniformed officer necessary? And isn't that scary to the patient?
Very good question, because that's one of the things that I've been working on with the team. So we do have, in the video you saw the Memphis CIT police. You do have CIT in Shelby County with the sheriff too. So they're involved as well. They just weren't in that video. But we've been working on just having just a basic, you know, t-shirt and khakis. And so they have been going out in t-shirt and khakis, some of them, when they're CIT officers. So we're making progress in that, but I agree. I don't want any uniform. So now that we're talking about it, this is another conversation I've had, and I think it'll take, you know, lots of change. I'd rather, instead of the police having to transport to our crisis unit in a police car, that our care team can bring them in an unmarked care team vehicle. Like we have, with our grant, we bought 2 care team vehicles. They're fully equipped with the communication back and forth between the police, fire, all of the technology you need to do like a telehealth assessment. Let's say they want to tie into one of our staff that's over here, we can do telehealth on the vehicle, but it's unmarked. So we'd really like to be able to transport in that vehicle back to the crisis unit or wherever they need to go. We haven't worked all that out yet. That's the goal. We're working on it.
Right. What you say reminds me that what you're doing is really, you're still developing this baby.
Yeah.
It's a work in progress, and it's not a finished product, and you continue to improve it, which I think is you're looking at what's going on, and you know that you're moving on to the next level. Suzanne Landau asked the question, why only UT graduating 2 psychiatrists a year? And
Yeah.
factors leading to that number.
Yeah, I talked to, and there's a new head of psychiatry, Dr. Cowan. He was at Vanderbilt. And so one of the things we're trying to do is create some excitement around community behavioral health, just around mental health in general. But part of it has to do with the salary. Like when you go into medicine, and it's just less pay overall than a surgeon would make. And so that's part of it. I try to entice people at Alliance by saying, look, we're an NHSC site that stands for National Health Student Corps. Sign on with us. We'll get your student loan paid off, and you can do 2 years of service. We have attracted licensed staff that way too. I mean, that's huge. Some doctors have, that might be like $50,000, $75,000 a year of their student loan paid off. But where I was going with the community psychiatry, they're trying to create something new and enroll new students to get, because some of the younger people, now that I'm in my 50s, I call them youngsters. they're, and I'm excited about this, more about a mission than a paycheck, even though we all have, I'm finding that from some of the younger people we're hiring. Is your, I want to change the world kind of mission. And so if we can at least, make sure we're paying them a living wage, attract them through the mission. But the only way they can find out about the mission is we have to continue to tell them what we do. Does it meet what your heart says? And then help us develop our mission. Give them a say in it.
I must say that the idea that you're working with a younger generation that really wants to change the world should make your mission easier to accomplish, because if you work in community mental health, or community health for that matter, we know that you're going to make a difference and have a strong sense of purpose. Marilyn Pavla, Laurie, have you considered developing a team that does not involve a police officer? And she says, I think back to the old mobile crisis teams or some other programs. What are your thoughts about programs like Cahoots in Oregon that involve treatment teams that serve neighborhoods?
Right. We've talked about that at length. I'm glad you brought that up. And when I first got on the call, I was talking to Bluma about this. When we first started Mobile Crisis, we got the grant, Midtown Mental Health Center that had Mobile Crisis. They were no longer, they kind of went out of business type of thing. And we took that grant over. We had, every community's unique. We had a couple of incidents, and I'll just be blunt about it. We had some of our staff were shot and hospitalized. One of them almost died. A couple of the females that went out, and this is in teams, nobody went out by themselves, were raped at a visit. So, until we work all that out, if I were to tell my team, and this is what I told Bluma, we're going to take the police part out of it, I would not have anybody going out. Those stories stay with the employees. So the ideal thing here in Memphis right now, as we continue to have these conversations, I'd like the police just to make sure there's no weapon, right? The story I was telling Bluma was there was the schizophrenic, there were a couple of schizophrenics that said they didn't have a weapon. They did have a weapon. Well, my staff's not going to know that. The family said they don't have a weapon. So they went out there and they were shot. I think we need to have these conversations so people know there's also, that has happened. And I don't know how to assure my staff that nothing's going to happen to them unless somebody makes sure there's no weapon. But do it in a humane way. Go out there and just say, hey, I want to talk, just make sure you don't have any weapons or whatever. And then, but that's where we are right now. So I have 120 staff that work in the crisis operation. They don't feel safe going in a mobile thing with just the EMT. I've talked to the EMT, I've talked to the fire department. They feel the same way. They don't feel comfortable because of the ifs. And we're just talking about a small percentage of the population. I don't want to say mentally ill or violent. We already know the data behind that. The data behind that is they're more likely to be victims of violence because they're vulnerable. However, there is this small percentage, like the person we heard about Monday in Colorado. They're finding out he was paranoid, not treated. We've had that. And so as the CEO, it's my job to keep my staff safe.
I appreciate your underscoring, A, the safety of your staff is paramount, and B, that although mental illness and mental health issues runs the spectrum from completely withdrawn to acting out, any kind of acting out behaviors, including obviously homicide and suicide and homicide, that the majority, of course, don't fall there, but all it takes is that one individual on an encounter that ends in violence. And I think that's an important fact for us to remember. Francine Brown asks, is the police officer armed? And if so, is the weapon visible?
The police officer is armed and the weapon is not visible.
Okay, thank you. And Megan Keel says, this is a comment. If we want change to come quicker, the mayors, police director, sheriff, city council, and county commission need to feel community demand to do something more quickly. If you want to be a part of building that collective community demand, please reach out to Karen Rubnitz or Lisa Harris to join Micah's team working on this issue.
Okay.
Good PR. Micah, the Memphis Interfaith Coalition for Action and Hope, is in active relationship with Laurie and AHS, and we would love to have more folks join.
I love what Micah's about and what Micah does. I envision something that we don't have right now, and I think we're moving toward that. You know, I'd like it to be where we just redefine what we're doing, and that's what we're trying to do. But when I talked to the fire department and they said, hey, you know, we don't feel safe, I thought, wow, okay. You know.
Before we have to stop, Laurie, let me just ask you a quick question. If I gave you a magic wand, or I waved my magic wand and said, you can have anything you want, what would you choose? What would be one thing that would make everything better?
Well, what keeps me up at night, when I took this job and my predecessor was working on it forever, I want the best crisis unit in the entire country, not just the state. And as we continue to find that, I didn't tell you about our property that we purchased. And of course, I should know the address, 3195 Summer. So it's 3.5 acres. We bought it. Broad is on one side, Summer's on the other. The through street is Malcolm. And we want that to be just a place that's welcoming. We're gonna build it and they will come. I want people to walk in and feel like they're getting, I'd like more people to walk in and get help than have to call 911. I mean, how about that? And then, you know, Mayor Strickland, he tweeted out something that I said, which was nice. So I think it's, you know, I just want to build the state-of-the-art crisis center and continue to expand access to care. Look at the Dahlia Center in Denver. We bought a 6-acre property in Hickory Hill from Community Foundation. That's a huge property. We could have all those services there, homeless services. We do a lot of work with Community Alliance for the homeless. You know, have a staff on site there. Christ Community is next to us in Orange Mound. Have somebody from Christ Community on our site and vice versa. Treat the whole person, address social determinants of health, which we just got a grant for social determinants of health from United Healthcare. There's so much to do. I can't just, I'm sorry, I told you like 500 things, but.
That's okay. I have a big wand, but I just want to say, obviously, I want to thank you. I think all of us now know more than we did at noon today about the issues that we are facing in terms of mental health and our community, and particularly in terms of crisis response. But I hope that I speak for everyone when I say that your dreams are also our dreams, and hope that they come true. I want to thank you and the participants today. Really appreciate it. Rabbi Aby, thanks again to you. Bluma, I'm going to turn it back over to you. Everybody, be safe. Thank you.
Thank you.
Thank you, Judy. So just as Judy said, thank you so much to Judy for being a wonderful facilitator, Rabbi Aby for giving us the Jewish lens into this issue, and Laurie for helping us to understand this complex issue and the critical work you and your team are doing. We will send out the link to everyone on the call today to the video. Thank you to all of you for joining us, and please mark your calendars for Wednesday, April 28th at noon for the final program in this series, Equity in Education, with Professor Daniel Keel of University of Memphis's School of Law. Thank you so much. Have a great day.
Thank you.